And now it's my pleasure to invite again L8-Kan to talk about PCO. There have been a lot of updates in the last years concerning PCO. And that's why we ask L8 because he is also interested in PCO questions to update us on the last knowledge of what PCO is, means, and how we manage it in our daily treatment.
Thank you, Professor Fisher. So hello again. My talk now is about redefining PCOS and management strategies. So in order to redefine PCOS, I first need to define PCOS. Then we'll talk about the current management strategies and draw some conclusions. So polling questions. This one's an easy one. Which of the following is not a criteria for the definition of PCOS by the Rotterdam criteria? That's 2003 Rotterdam criteria. Yeah, so funny enough, insulin resistance is not although we don't not know the etiology of PCOS, insulin resistance is a very strong contender. Another polling question. And this is, I put this question down because it's a very common clinical scenario. You get patients coming to you, she is asking, do I have PCOS? Somebody did an ultrasound or she's got some acne, and then she wants to ask you, do I have PCOS? And she really wants a yes or no answer. Or the other scenario is the mother brings the 16-year-old girl all in a panic because there is suspicion that she might have PCOS. Again, irregular periods or acne, and then she asks the question, does my daughter have PCOS? Difference between C and D is that C is we need more information maybe, and D is probably we know the answer, but it's just too difficult to explain to the patient. And I'm just interested to know your reaction. There's no right answer, whether it's C or D. But that you can see that's the typical scenario, and that's why this lecture, I suppose, is to try and give an answer to this this patient or this mother. So why are we talking about polycystic ovarian syndrome? If you have a condition that has a prevalence of up to 25%, 1/4 of your women have it. 1/4 of women in the reproductive age group has it. Question is whether this is actually a disorder or, it's so common. The etiology, like I said, is unknown, but we still need to know, and why patients want to know and why mothers want to know whether their daughters have it is because it's not just a simple label. We know that there are sequelae to this condition, this polycystic ovarian syndrome. There are metabolic syndromes. We're talking about cardiovascular, dyslipidemia. We're talking about infertility, obviously, and also a lot of psychological issues, body image issues. So at the present, what we're trying to do with the management of PCOS is to just target, whatever the patient is presenting with. Patients presenting with irregular periods, not interested to get pregnant, we target that. Patients is worried about her hyperandrogenism, either hirsutism, acne, we target that. And then infertility, we just target that. But more and more, we are thinking that, maybe it should be an all-encompassing thing. And don't forget about the psychological issues, the obese, the body image issues. The problem that we've had we know polycystic ovarian syndrome, the word syndrome means it's a collection of signs and symptoms, and we all know these signs and symptoms. The problem is, how do we define it? And we definitely need to define it, whether we are doing research, like, for poor responders, we've got the Bologna criteria. We also need to define it so that we can then move forward to do research. And when we talk, say, based on, this polycystic ovarian syndrome population, this treatment works, that treatment doesn't work, we still first need to define it. The problem with defining it is that there's always been some disagreement amongst the world what polycystic ovarian syndrome is. The Americans have always been very strong on the hyperandrogenism part, the insulin resistant part. The English, and Europe more on the polycystic ovary morphology on ultrasound. I put down Australian, although we don't have much influence on PCOS in terms of their guidelines. We had a guideline in 2012, but Australian is also important because the current definition based in 2018 is led by Monash University. It is a world thing, but it's led by Monash University, and everybody knows about the Rotterdam criteria. The Rotterdam criteria, like the Bologna criteria, is very important because it allows people to do actual research. So based on the Rotterdam criteria, this patient has polycystic ovaries. You need 2 of the 3 criteria. And then, yes, she has it. And therein lies the problem of why you have up to 25% of your women with polycystic ovarian syndrome based on the Rotterdam criteria. Oligo and ovulation, some irregular periods. What is an irregular period? So, very easy to say someone's got irregular periods. Polycystic ovaries on ultrasound, that's probably one of the most common things that you get when patients come to see you. Somebody has done an ultrasound and shows polycystic ovarian morphology. You add irregular periods, you got 2 out of 3 criteria. So we know Rotterdam criteria has got lots of problems, but having said that, it is still, the paper was in 2003, is one of the most quoted papers in all publications, the Rotterdam criteria. But because of that, we're talking about maybe up to 20 to 30% of the women, having this label of polycystic ovarian syndrome. And this is why the current criteria is trying to address a lot of the problems with Rotterdam criteria. We know that they're trying to define exactly what the ultrasound criteria are, what is hyperandrogenism, and then, really, should you be doing an ultrasound and labeling someone with polycystic ovarian syndrome if she's only 1 year post-menarche, and then, most of them do have some sort of, not only 1 year, up to 8 years, up to 8 years post-menarche, they still have, when you do an ultrasound, almost all of them will have some form of a cyst. Don't forget about ethnic variability. So we're talking about hirsutism, and what one culture considers as hirsutism, another culture may not consider as hirsutism. And for a long time, up to now, Rotterdam criteria doesn't talk about the sequelae, the cardiovascular, the dyslipidemias, the long-term higher incidence of diabetes, and more important, the psychological issues. So this is it. It is a very, very comprehensive reading, very, very comprehensive reading. I've got the website. It's on top. It's just a PDF. It's quite a thick book. And this is led by Monash University, Professor Helena T at Monash University. And it is an international evidence-based guidelines on the assessment and management of PCOS. And it was published in 2018. It is a massive work, but it does have consensus both in ASHA and the ASRM. We're talking about 37 organizations, lots of meetings over 15 months. So this was published in 2018, and they have a new publication coming out. So in 2023, probably in the next few months, there will be a new publication, an update on this 2018. And my good friend, Michael Costello, is in that group. And he said that, they have looked at all the studies that have contributed to 2018. They've drilled down the studies and they've taken a lot of studies out because they do not meet criteria. But more or less, it's going to be the same, except for the AMH criteria. So they're going to use AMH as a possible, but don't quote me, wait for the paper. AMH as a possible guideline to diagnosis. So a few things to say before we drill down into this guidelines in 2018 is that it has to, and it does, endorse both the Rotterdam criteria, and there is an American NIH phenotype criteria published in 2012, which I will show you in the next slide. It also says that within 8 years of menarche, so if your daughter, the girl, has a period starting at 12 up to when she reaches 20 years old, ultrasound is not recommended. And you must have both hyperandrogenism and irregular periods are required. Ultrasound is not recommended. It also says, if you read it carefully, is that you've got to ask the question: do you need to make the diagnosis at that early stage? Because at present there is no pharmacological medication that will delay or take away the long-term cardiovascular sequelae. At that time, 2018, anti-mullerian hormone was not thought to be adequate for diagnosis, but I feel that they're going to use that in the new criteria. And importantly, especially in the 2018, and more so in the current publication, they're talking more about the psychological features and also the management. So I promised that I'll show you the NIH, and then that shows you, a lot of the things about the difference between Americans and in the, English stroke Europeans. The Rotterdam criteria, based in Rotterdam, although it was a world thing, it's more a European thing. And the Americans still came up with their own. The National Institute of Health came up with, and it's more or less the same thing. They've got things like, but up to, I read a paper was published last year, so 2022, that still use this criteria. So phenotype A, which is everything, all three criterias. And you can see the recurrent theme there is the androgen excess. So let's have a look at the contents of this 2018 publication. So the first part is, how they came together, who's involved, what sort of agreements did they get. But if you look here, starting on this side here, they will drill down into irregular cycles, but they will go down into exactly what they mean by irregular cycles. So not so much to say oligo and ovulation. They will talk about hyperandrogenism, and they will break it up into clinical and biochemical androgenism and the ultrasound criteria. And that's very, very comprehensive before you can call somebody, diagnose somebody as polycystic ovarian syndrome. There is a whole section here, which we do not have, which is a main feature over and over again in 2018 guidelines about the psychological aspects, body image aspects, lifestyle management, so non-pharmacological conditions. And they talk about with the non-pharmacological conditions, as we know, the first line treatment of all PCOS is lifestyle changes. So we go on to second chapter, the second page of the contents. So like I said, it is a comprehensive reading. We talk about the pharmacological treatments for non-fertility indications. And that's where you will get your answers. Unfortunately, these are answers based on either evidence-based medicines or based on consensus of the people meeting. There are lots of people from all around the world. But if they do not have evidence-based medicine, they will do a vote and they will call it a consensus statement. Because the question we're going to ask is, is metformin going to, delay diabetes? Is metformin going to help with the cardiovascular dyslipidemias? So these are the non-fertility, and I'm not going to touch on this. I'm just going to concentrate on the assessment and treatment of infertility. Then this is more on how they were grading, how they were giving the grades and the recommendation. It is very comprehensive. It is current evidence. The strength of the recommendation is based on current evidence available at the time. So the grading system is this. If it's 1, then it is against the option. If it's 4, then it's a strong recommendation of the option. Then based on the option, they will say, what is the quality, how strong do they recommend this? Ranging from high to very low. To give you an example, yes, besides that, we mentioned that, evidence-based research. And this is where this group would look at all the available data. Obviously, there's lots of people, so they can divide the work up. Look at all the current available data. If there are randomized control trials, those will be taken first, and then meta-analysis, and then it goes on. As you expect, there are not a lot of randomized control trials, and even if there are randomized control trials, these may not be very strong evidence in support or not in support of a certain recommendation. But they'll take that into account, failing which, and as you can see, even in this example, when they talk about ultrasound and polycystic ovarian morphology, you'll find that there is no evidence-based recommendation. So no evidence-based recommendation for ultrasound. Second line from this would be clinical consensus recommendation. That's just a voting based on the people that are sitting on the committee. And then lastly is clinical practice point, is what they would think is a good idea, okay, without really even a voting system. So for example, if we use ultrasound as a criteria, so we need to move up with the time. So Rotterdam criteria was 2003. This is 2018. And ultrasound, as you know, technology has moved up. What you couldn't see in 2003, you can now see. So if we talk about, there used to be, I think up to 9 follicles, and then, 10 centimeter cube volume. So you got to move up with the time. So if we're using, if they're saying that if it is 8 megahertz transvaginal probe, which you can, see a lot more, than in 2003, they must see at least 20 follicles. And that would be the 2018 guidelines. And then you can see that it's going to go up, as technology improves, and you can see more, that number might increase. But here also is where I was talking about the 8 years post-menarche, that it's really not recommended to do an ultrasound. So this is just the ultrasound criteria, one of the Rotterdam criteria. Moving on to irregular periods. So again, Rotterdam criteria said oligo and ovulation, which most practitioners would just translate as irregular periods. So I asked a question, have you got irregular periods? She said, yes. So, okay, you got one of the 3 Rotterdam criteria already. So here's very, very specific. So if you say 1 year post-menarche, you need to be greater than 90 days, okay? And if you are 1 to 3 years, okay, this one, 1 to 3 years, 1 to less than 3 years post-menarche, less than 21 to greater than 45. So these are very, very strict criteria which you can use, okay? To when you ask the patient, have you got irregular periods, you got to say, when did your menarche start? And therefore, do you fulfill the criteria of your irregular cycles and ovulatory dysfunction? But again, most of that is clinical consensus or clinical practice points. Very hard to do these sort of studies. In the hyperandrogenism, divided into biochemical and clinical, here we have evidence-based, And again, hyperandrogenism. So the question is, if I've got a little bit of acne, if I've got, hirsutism, then, you got to think about what race are you, is that normal for your race? Okay. So this is going to be clinical practice point as you expect, acne, what constitutes clinical hyperandrogenism. But in the case of biochemical, yes, you've got, at least you've got things that have been shown by research that we're talking about free testosterone or some form of calculated free testosterone. So second part of my talk is on management strategies. So we talk about redefining PCO and then management strategies. So this book, I'm just going to confine it to infertility management, so assessment and infertility treatment. Chapter 5. So why are we talking about infertility? Because it's so common. It's so common in polycystic ovarian syndrome, and most of the reason why PCOS women suffer from infertility is because of anovulation. So so much so that Roy Humboldt said that PCOS is the most common cause of anovulatory infertility. And treatment, as we know and as we should abide, lifestyle changes is number one. This is from the 2018 recommendation, but going on to pharmacological, surgical, and in that 2018 and supported in the 2023 is this thing called this IVM thing. This is the chart, simple algorithm, and you go look right at the top. Okay. Non-pharmacological, this is management of infertility. Non-pharmacological, first line would be lifestyle changes. I think that is true for everyone. You should, if you're obese, you need to lose weight. If you are a thin PCOS, then you need probably to think about lifestyle, as in not exercising too much, diet, body image, think about all that. Then you move on to first-line pharmacological treatment. And we'll spend some time on letrozole. I think I was supposed to say that letrozole is off-label treatment in most countries. In Australia, definitely. I'm not sure about Singapore. Whether we talk about letrozole or even metformin, these are off-label. But these are the first line, and it goes from top to here, gonadotrophins. And this might seem strange, whether you can use metformin on its own, but there is evidence-based medicine that metformin on its own does work. It's not high up here, but it's down there on its own, and especially in obese women with evidence of insulin resistance. But still, they would recommend that even if you use metformin, you should add clomiphene citrate to it. So after that would be second line, and we're talking about gonadotrophins. So that's first and that's second line. Seems to be the same medication. It is the same, but the reason why they have it in both is that, in certain countries, whether there is availability, whether it's less more cost effective, you might think about going straight to gonadotrophins. And laparoscopic surgery, just talking about drilling. And only when it does not work, does the management of infertility for PCOS goes to IVF. Okay, obviously this is not a real life scenario, because if you got a woman that's got PCOS and tubal blockage, PCOS and male factor infertility, you just go straight down to infertility. This is just for in general in a textbook. So just want to spend last few slides to concentrate on letrozole. It's offline, but it's got very strong evidence, mainly from this paper in the New England Journal by Legros in 2014, which comprehensively shows that, in the head-to-head study between letrozole and clomiphene, which, was and it probably still is the #1 used medication, that letrozole increases both live birth and and both pregnancy and live birth. And not only that, it decreases the OHSS risk and decreases the not the OHSS, hyperstimulation and twinning rate. Okay, so really there's no reason not to use letrozole unless it's not available in your country. But all of this, I'm not going to go through them, but you know that all of this is evidence-based. Okay, and you read down is exactly what that algorithm says. Don't forget Clomid. You can use metronidine. You can use metformin, but try to encourage to add on Clomid on top of metformin. So it should be combined with metformin. The conclusion is that polycystic ovarian syndrome, is a syndrome. So it's a collection of signs and symptoms, always going to be difficult to make the diagnosis without these sort of strict guidelines. And Rotterdam criteria was excellent because it allowed us to say, okay, based on Rotterdam criteria, it allowed us to do research, but it was not comprehensive enough. So right now, the 2018 and soon the 2023 international evidence-based guidelines for the assessment of management of polycystic ovarian syndrome is the best current guideline that we have for diagnosis, assessment, and management of this problem. Thank you very much.